Now, I'm going to keep moving around. I've taught medical students for 35 years, and one or two of them are around here. And it's safer to be a moving target here, actually. But I'm going to start out on a serious note. I want to say thank you very much to Ian Powell and to the whole of the ASMS team, not only for your recent hospitality, but you've continued to support us in a thoughtful way, the Christchurch rebels, that is, through 20 years of perhaps some of the most turbulent times in our medical history. Thank you, Ian. Did I read that okay? Right, today it's about secondary unmet need, okay? You know, the trouble started with the health reforms, but perhaps the first warning step was the Core Services Committee in 1992. You know, we were going to recapitulate the Oregon pathway, but the trouble was the New Zealand public wasn't ready for that. And they certainly weren't ready for the language that went with it. However, they did give Sharon Crosby some sort of a gong for doing it, even though it disappeared within a year because it wasn't doing the job. But, you know, the spin doctors went away and they thought about all this very carefully. And they came back in 1998 with what was called the National Waiting Time Project. And the whole of the language had changed. Responsibility had become accountability. Rationing had become prioritization. And perhaps the worst of all, waiting lists had become waiting times, which sounded so good. However, by September 2006, in Canterbury alone, 24,000 patients had been refused a first specialist assessment, and 22,000 had been removed from the waiting list. Here in Christchurch, on one day, we removed 4,400 patients from our waiting list. Result, increasing unmet need. Things were very different back then, weren't they? I mean, this bloke here had a lot of hair. He also had a lot more money than he has now, too, I can assure you. But he did have a long waiting list. It says here, according to the media, he had more than 150 people on his waiting list. But at that very time, I referred this system, which was then called the booking system, to the Regional Ethics Committee, and they found ethical issues with it. But the government did not listen. Do you know about Orwellian speak? George Orwell, you know, was not only a neologist, he invented many of the phrases we use today. He was also what's a self-styled dystopianist, which meant he described when societies aren't really working. And he would have loved what happened to this. He could have made mincemeat out of it. Because, you see, when they say the waiting list is only 4 months long, what they mean is, if your operation won't be done within 4 months, we won't have you on our waiting list. Think about it. This slide, I think, typifies the current situation. Here's this reservoir of community need being fed by disease, and there are all these increasing number of constrictions in the pipeline that leads to acceptance and treatment. More and more, you know. Now we have not only a clinical threshold and a financial threshold, we have the National Waiting Time Standard, we even have now what are called health pathways, which again sound wonderful, but are in fact rationing in a different name. And what's the purpose of all this? It's to reduce the expectation of the communities and to reduce the expectation of GPs and to end up with less and less coming out of this end. This is referred to in a whole host of managerial documents by the hateful metaphor, altering the trajectory of demand. How hateful is that? How big is the unmet need? Well, there's only been one serious attempt to measure it, and this is it. This was done by the Health Funds Association in September 2013. They paid for a big survey to be done of 1,830 households, and they found that of not only letting alone all the people who got surgery, there were another 280,000 who were told they needed it, and of those, 170,000 weren't recorded anywhere. The Minister of Health completely rubbished this on the basis of what he called bias and lack of scientific integrity. What he didn't say to you is that this company, PNS, is the one that he himself uses to get opinions from the public. The charity hospital has many friends. One of our dear friends is Garrick Tremaine. Those of you from Canterbury will know Garrick Tremaine, probably one of our most famous cartoonists. And Garrick gave us this cartoon and he said, hang it. Well, in fact, he said, auction it off to make money for your charity hospital. We couldn't. It's on our wall. You'll see it as soon as you come through the door. The fact is, Mrs. Throgmore, if you're well enough to know you need an operation, they consider you're not sick enough to get one. You're going to have to work with me today, you people. In September 2003, I had several jobs apart from my day job. I was chair of the College of Surgeons in New Zealand. I was also an elected member of the District Health Board, and I was giving a lecture in Melbourne, on workforce. And I was pretty tired at the time, and like a few of you, I was resting my eyes and thinking, this old duffer, I wish he'd stop talking, and I could get my talk over. And then he started to say a lot of sense. And he came out with this document here about surgical services in Australasia. And what he said was, we're headed for charity hospitals, he said. And that was my epiphany. I came back and I said, let's have a charity hospital. We've got to do something positive. So we put together this team here. This is my wife, Susan. We were on the same dissecting body at medical school, which wasn't as romantic as it sounds, actually. And then there's me. And in fact, actually, Sue is an adolescent physician. I, being a surgeon, it's commonly known in Christchurch that she will chat you up and I will cut you up. And this is Randall Allardyce. He's a scientist and a good friend, and he's a very famous Scots piper. And it wasn't until I saw this picture that I realized that can give you an enormously long right arm. And this is Brian Stokes. He's a very well-known lawyer, and I'm glad he's on our side because he's kept us out of jail for a long time, actually. Anyway, these are the concepts that group came up with. Canterbury-wide access for some patients who can't access the secondary health care they need. Only 2 full-time paid employees. Only 2. Everybody else must give their time for nothing, and this will be totally funded by public donations. We would not take 1 cent of government money. We would immediately have to employ 6 people to account for where that cent went. And we took this idea to the Canterbury community. It's not known as the People's Republic of Christchurch for nothing, you know. They were determined to prove that this would work. And in fact, Sir Richard Hadley came along and he got the old faithfuls to play the young hopefuls, and there were events in Hagley Park, and the kids laid on music, and there were charity bike rides. But I have to tell you about this. This is the Mount Pleasant Bowling Club. And they said, we've got a big check for you. And will you come and receive it? I said, naturally. They said, will you present the prizes? Well, when I arrived, they were having their bowling day, and there was a big banner up to say, National Championship sponsored by the Mad Butcher. So I ended up standing there holding an enormous tray of meat. And an old octogenarian padded up to the front to get his prize, and before I could stop him, he grabbed the microphone and gave a 5-minute speech thanking me, the Mad Butcher, for having sponsored their organization for all these years. Anyway, we looked at all sorts of places, and we thought this was absolutely perfect. It was an old villa. It was falling down, but we liked it. It was a very bucolic environment, a leaking roof, long, drafty corridors, very advanced electronic systems, and a resident cat called Sylvester. Oh yes, this is the architect. This is the new health system. Here's the private wing, and here's the door. Here's the public wing, and there's the door. The architect reckons if they're sick enough, they'll find some way of getting in. Anyway, the public really responded very well, and we did the place up a bit, a few licks of paint, and this was the big opening. The president of the Australasian College came across from Australia. The head of the nursing organisation came. Even the bishop came, although no one can remember inviting him. Anyway, we had just this little place at the beginning, but all I can tell you is it's grown like topsy. We've expanded that one. We've added this big wing out here. We've even bought a residence at the back here, and this lady here, well, we keep talking to her. But what we have now is we have an orthopedic standard operating theatre, one large recovery area. We have an endoscopy and smaller theatre with its own recovery area. We have the dental association do dental work for us, and we have a counselling service which has been run ever since the Christchurch earthquakes. We even have a virtual teaching centre where we can teach doctors, registrars, nurses, and so on. For those of you who don't know what colonoscopy is, this is the first known example of it from a museum in Belgium. All I can say is you still need this many people, but the equipment costs a tad more. Who gets to be a patient? Can't access the public healthcare system, affected by something that affects their quality of life or their employment prospects, can't afford private care, no health insurance, don't qualify for ACC, have to sign legal documents that they meet these criteria. What are we about? We are about high quality, timely treatment. We think that's really, really important, very important. We think it's important for two reasons. First of all, there is the humane aspect of it. This is known in Canterbury as the Dear John letter. It basically says, push off and don't bother us. It's signed nicely by the DHB, but it means you're not going to get treatment by them. And they all come with one of these, every one of them. And I can tell you this, that the young people express very serious feelings of anger about it, and the older people tend to express feelings of abandonment and really serious loss of hope. They've been let down by a system that they believed in all their lives. We also believe that timely treatment is more cost-effective for various reasons that are self-evident, really. And lastly, I commend you, there is a very large world literature now showing that investing in health at an early stage is financially most rewarding. We get a lot of old jokers, particularly the cataract patients, and this reminds me of one of them who said, I said, how are you getting on? He said, oh, great, doctor. He said, when I drove here today, he said, it's the first time I've seen those white lines for years. Anyway, this is good. Judy, do you see that elderly couple at the other end of the counter down there? She says, yeah, what about them? He says, I was just thinking, that's probably what you and I will look like in about 10 years or so. You do realize that's a mirror at the end of the counter, don't you? What do we do? Well, these are some of the things that we do routinely. Hernias, hemorrhoids, cataracts, carpal tunnels, colonoscopy, a lot of women's surgery. We do more elective women's surgery than the DHB. Some orthopedic surgery, and a hell of a lot of counselling. But this list changes all the time. We try to fit in the gap, and that gap changes from year to year. So this list is different. We're what the public service is not providing at any time, and what people can't afford to treat in private. And that gap moves, and we try to move with it. Give you some idea of the sorts of numbers of people we're talking about. These are the numbers of staff, volunteer staff that worked for us just last year. Lots and lots of people, many, many people. How many sorts of procedures do we do? Well, these are appointments, these are follow-ups, and you can see here that since 2011, we've been treating somewhere between 1,200 and 1,500 procedures a year, which is a fair bit. What did it cost? Well, all the buildings, the cost was 4.5 million, annual running costs 680,000, all met by public donations, bequests, and special fundraising activities. We were audited last year, and 82% of every dollar went on direct patient care. We have an enormous number of volunteers. At the moment, there are 300 active volunteers. I couldn't put you all their pictures up here. Yeah. You'd nod off like I did when I was at the meeting. But this guy does the garden. This chap travels down from Hawke's Bay to operate. These nurses have both worked with me, the poor darlings, for over 30 years, and they're still there. Even the cat has a role. This book, Sylvester the Charity Cat, sells on 3 continents and brings in large amounts of money to pay for what we do. We're not the only examples. There's a regional charity hospital in Auckland called Arch, and several groups around the community, like the Taranaki Community Health Trust, collect money to help pay for you if you need private treatment. What are the studies of unmet need? Well, if you go to literature, you'll find that there are many studies looking specifically at certain categories of unmet need, like need for cataract surgery, need for cardiac surgery. But studies that look at all of secondary healthcare, there have not been that many. These are some of the main ones: Canada, Italy, Thailand, even Sierra Leone, although they did do that with American money, apparently. So there have not been that many. But it is now generally agreed that you should be regularly assessing the need for secondary services that are unmet. In fact, the only issue isn't that. The issue is how should it be done? Because all of these ones use different methodology. It's now become very fashionable to talk about this. It's flavour of the month. Not only has the minister decided he wants to measure it, lots of other people have joined in. The Canterbury District Health Board has suddenly decided it wants to audit all its unmet need services. So this is suddenly the flavour of the month to do this. The only problem is how to do it. So we decided we'd get together a group of the most senior and accomplished academics from around the country with a track record in this area. And there they all are. And what we propose to do is a study, a pilot study, looking at the proper methodology for New Zealand. What we want here is something that is accurate but affordable. And it's a balance between those two requirements. And getting that balance right is not easy. So in our study, not only we're looking at both Canterbury and Auckland, and we're looking at general practices in Auckland and in Canterbury. So they're going to have their input into this, but we're also going directly to the public with face-to-face interviews, telephone interviews, and web-based surveys. And then our clever scientists will put together, by what they call multivariate analysis, whatever that might be, what is the best method for New Zealand. How did we manage this? Well, we have received monies from various sources. Canterbury Medical Research Foundation did a formal survey of this, a scientific survey, and ASMS have also been big contributors, as have several other trusts. So to let you know on progress, the 3 population arms are being done by a company that is actually doing the job right now. They're about a third of the way through the job as we speak today. The survey, so the survey arms will certainly be finished before Christmas. The GP arm should be finished by March next year, and at that stage we were expecting to publish our results. We believe that as stage 2, there should be an independent biennial assessment of unmet secondary healthcare need done by a totally independent committee and reported on to the public. We've given our views on the need for this in an article in the New Zealand Medical Journal last year. And to boil it all down, we think that asking the DHBs or the ministry to do it would be like asking Bart Simpson if he was a good boy today. I have to say, I like to say this in a semi-humorous sort of way, we're talking about a very serious and increasingly large problem for our country and for the people who cannot access simple health care that they need. And I'm afraid as the medical profession, are going to have to take some responsibility for that situation, having arisen and for getting worse and worse. We are not saying anything about it. And as an old college man, if there are college people here, I pose the colleges of New Zealand these serious questions. What are their official positions on unmet secondary healthcare need? They're very quiet. What do they intend to do about it? I don't know. Do they support an independent, robust system for its regular assessment and reporting? Nobody knows. All I can say is thank you to ASMS for supporting me to try. I think, when it comes to the problems that face mankind, the serious philosophers have made a serious point, you'll find. They'll say that it isn't really about the how, the where, or the when. It is about the why. And I think the answer to that question comes from John Donne, who said, "No man is an island entire of itself. Every man is a piece of the continent, a part of the main. Any man's death diminishes me because I am involved in mankind. And therefore never send to know for whom the bell tolls. It tolls for thee." Thank you.